The first speaker we're going to have this afternoon is going to be Fiorita Poulakaki, who is a breast surgeon from Greece, head of a breast surgery clinic in Athens. That's her main occupation. And on the side, she's vice president of Europa. Many of you already know her. And I think she's a fantastic advocate, and she's going to talk to us about the effects of COVID on diagnosis and prognosis. Fiorita, your turn.
Thank you very much, Nicole, for the nice introduction. Thank you all. I would like to welcome you all here in this evening session about COVID and the impact on breast cancer. It's a great honor as well as pleasure for me to stand here before you to discuss about this topic. At this point, I would like to thank the organizing committee for inviting me, and I declare no conflict of interest during this presentation. COVID-19 pandemic changed the way breast cancer was managed worldwide in an effort to conserve limited resources and triage patients according to medical necessity. You realize that this led to temporary suspension of breast cancer screening programs and closures of operating rooms for elective procedures. Imagine somebody having to have a mastectomy with immediate reconstruction and deny the reconstruction because it's considered an elective procedure. This is a snapshot from our website under the breast cancer facts section. I advise you all to go and have a look at it. It's a fantastic section, a fantastic website. Always based on the 2020 Globocan estimates, breast cancer is the most common cancer in the WHO European region with 576,300 new cases, and the women who died from breast cancer in 2020 were estimated 157,000 in WHO European region only. Regarding COVID-19, you can see the data from the WHO recently updated. As of early February 2021, the COVID-19 pandemic led to over 2 million deaths with over 261 million confirmed cases in Europe. If we want to have a look at the mortality rates, looking the one beside the others, you realize that globally, the mortality rates from COVID-19 is about 3.4%. The breast cancer mortality rates, fortunately, we see going down the curves every decade, and it's now about 30%. But for metastatic breast cancer, it's more than 90%. During COVID-19 outbreak, Europa conducted a survey where the following common issues arose in numerous European countries on the effect. It took time for all the health systems to organize COVID-free paths and to implement treatment guidelines for safe access. Many treatment plans changed, screening was suspended, treatment was prioritized according to urgency, shorter hospital stays were advised, and the use of telemedicine increased. This had as problems a reduction of health structure capacity, the suspension of screening and elective care, later diagnosis of more advanced breast cancer in some cases, hospital stays were shorter, and an important thing, no access to caregivers and family. The patients usually felt abandoned and alone. All the graphics and tables will be shared with you later during Barbara's presentation. You will have the time to enjoy it. On April 2020, the Transformed Breast Cancer Together Group, a multi-stakeholder initiative, published a statement paper in order to address the challenges created by the COVID-19 pandemic and the impact on breast cancer patients. The challenges in accessing appropriate treatment and care are 1, diminished resources to care for breast cancer patients, 2, delays in screening and diagnosis in the current climate, delays in breast cancer treatment, discontinuation of clinical trials. Can you imagine that during clinical trials, it is sometimes very critical for patients to receive these treatments and sometimes leave them without an option or hope for treatment? Of course, emotional distress caused either by uncertainty of treatment, follow-up, COVID fear, and of course emotional distress generally for cancer survivors. This study is the first of its kind to estimate the impact of the COVID-19 pandemic on cancer deaths due to delays in diagnosis in the UK. This is a national population-based modeling study which estimated the impact on net survival at 1, 3, and 5 years after diagnosis to calculate the additional deaths that can be attributed to cancer and the total years of life lost compared with pre-pandemic data. This is a table where you can see the distribution of patients by referral pathways, stage of cancer, 1, 3, and 5-year net survival in the pre-pandemic cohort and its pandemic scenario. What we realized from this study is that screening and early detection work, and when they are stopped, the cancer death toll increased. It was estimated a 7.9 to 9.6 increase in the number of deaths due to breast cancer up to year 5 after diagnosis, corresponding to about 801 and 344 additional deaths only in the UK. The Dutch National Breast Screening Programme stopped in week 12, 2020. The impact of the suspension and restart of the screening program on the incident-detected and non-incident detected cancer was investigated. In week 26, it resumed at 40% capacity, in week 34 to 60%, and the incidence was calculated overall by age group, clinical stage T, the tumor size, clinical TNM stage, for each period in 2022, and this was compared with previous years, 2018 and 2019. The decrease in incidence was seen in all age groups and mainly occurred for small tumors and in situ tumors, DCIS, clinically tough T1, and stage 1 tumors. Screen-detected cancers decreased by 67% compared with previous years. Non-screen-detected cancers decreased by only 7%. Likewise, although the number of symptomatic cancers in this cohort initially decreased in the spring, the non-screen detected cancer volumes rebounded quickly. And in fact, it overtook the numbers of 2019 and 2018. All the cancers that were missed, they found them later. These numbers equal about 2,000 potentially delayed breast cancer diagnoses. And up to August 2020, there was no indication for a shift towards higher stage after the restart. The key impact may emerge from a delay in screening examinations rather than from a delay in imaging workup of symptomatic patients. The COVID and Cancer Modeling Consortium has established a screening working group, including a group focusing on breast cancer screening. The aims of this group include documentation and estimation of disruption of screening services, the impact of breast screening disruptions in a range of international settings. And the outcomes are breast cancer incident, delayed diagnosis, mortality, and the impact on referrals to treatment services. Some countries paused their breast screening program in response to COVID-19. Here you can see a summary of these pauses in different countries. In Europe, generally it ranges from 2 to 6 months. The predicted impact of delays in time to treatment initiation on the stage distribution of incident cancers are the resulting excess mortality, and you can see it here in the table. As a result of stage shift, 6.3 and 22.3% additional deaths were predicted for 3 and 6 month disruptions. The estimated excess mortality for screen-detected and clinically detected cancers, you can see it here separately. This shows the higher burden for clinically detected tumors for equivalent disruption. And of course, if the disruption is longer, for screen-detected tumor, then we see a greater excess mortality to this group. Here you can see very interesting data coming from a meta-analysis from the Mayo Clinic performed on 7 studies on screening mammography. Pooled analysis ratio were significantly lower. The most concerning potential effect of a decrease in cancer screening is an increase in cancer mortality. This is the most important thing. That's what it's all about. Mortality data regarding decreased screening during the COVID-19 pandemic are not yet available. Screening in the US has been documented to prevent around 10,000 breast cancer deaths over the lifetime of a cohort of 50-year-old women. This is moderate quality of evidence for diminished screening of both breast and cervical cancers, and there is a downstream result of the pandemic that may be an increased incidence of advanced stage tumor as well as a rise in cancer-specific mortality. This is the last, definitely not the least, but most recent study that we have where different outcomes were evaluated. Clinical and demographical features, breast cancer stage and diagnosis, rates of neoadjuvant therapy among women presenting with newly diagnosed breast cancer before and during pandemic. There was a total of 573 patients identified, 376 in the pre-COVID cohort and 197 in the during COVID period. If you can see this table, there is no significant difference in the type of surgery. Breast conservation surgery, unilateral mastectomy, the type of axillary surgery, there was no significant difference in all these types of surgery. Additionally, there was no difference in respect to axillary surgery within the clinically N0 group compared to the clinical N positive group. One really important finding was the impact of neoadjuvant endocrine therapy on breast surgery. Although more patients underwent neoadjuvant endocrine therapy during COVID-19, which actually worked as a bridge between diagnosis and operation, especially when we had a lack of operating theaters, this did not significantly change the distribution of breast surgery type. It didn't change anything, really. The conclusions of this study: there was a significant increase in neoadjuvant therapy during the COVID pandemic, especially for hormone-positive patients and HER2-negative disease. There was no change in method of breast cancer detection, no change in the stage of breast cancer in diagnosis. There was only a slight non-significant shift with increased stage 2 and 4 disease. There was no significant change in breast surgical procedures performed, no difference in tumor biology, and definitely a longer follow-up is needed for cancer outcomes. Wrapping up, COVID-19 pandemic has led to a natural experiment allowing evaluation of the effects of a temporary cessation of screening of breast cancer outcomes. The effects of the pandemic on cancer stage and diagnosis, patient prognosis, and breast cancer mortality are what is most clinically meaningful, and for this we will need long-term data. It is to be hoped that all these distinguished authors of all above-mentioned studies will continue to report their follow-up observations, enabling a more complete understanding of the downstream effects of the pandemic. At this point, we should highlight the important role of the guidelines that all scientific organizations so generously handed out to us, scientific community and patients. Thank you very much.